Hi, my name is Kevin Murphy, and I'm more than honored to be asked to talk about the use of SonicWeld. And we're going to be talking a little bit today about the use of SonicWeld in fabricating barriers for GBR. And I'd like to use this as our outline, what we're going to talk about today. First of all, we're going to talk basically about what is it. There's a lot of confusion about what this technique is all about, and hopefully I can explain it to you. We're going to go over some of the concepts about how this whole idea of ultrasonically putting things into porous bodies came about, and I think you'll be surprised about what the origin of this concept comes from. We'll do a little bit of basic science about biodegradable barriers, what to look for, how they're designed, and what are the parameters that are involved. We'll talk about the basics. How do you put this material in? How do you shape it? Very, very briefly, we'll talk about some histological evidence that we are beginning to develop about whether or not this technique gives us vital bone. And the core of today's discussion will be on the shell technique, which has been first described very eloquently by a good friend of mine, Gerhard Egelhaut from Memmingen, Germany. Just a fantastic oral surgeon who really deserves a tremendous amount of credit for bringing this concept and refining this technique to our community. And then we will talk about, finally, the extraoral frame technique for vertical augmentation. So first, we'd like to talk about what is this SonicWeld technique. Well, the material is a biodegradable material. It's made up of a 50-50 homogeneous ratio of poly D and poly L lactide acid. So the D and the L are isomers. That means that they are mirror images of one another, but has that same chemical composition, but they behave differently. So that's why classifying the isomers is important. The PDLLA polymer is broken down through a process of hydrolysis, so that's where water gets in between the polymer chains, and the polymer chains are broken down via the Krebs cycle. This degradation of the barrier usually occurs without irritation, and the period of degradation is anywhere between 12 and 30 months. But the key to this technique is that we use an ultrasonic energy to drive the pins into the boreholes that we've created in the bone. And we'll show you some videos about how this is actually achieved, but it's actually quite unique because we're able to change the state of this initially hard plastic into a molten plastic within a period of 2 to 3 seconds without raising the temperature and thereby causing damage to the bone. So what's actually happening is the molecular structure of this polymer is being changed so it turns into a liquid state and allows the liquid of the polymer to go into the pores of the bone. The ultrasonic energy is removed and then it immediately solidifies. So it's a way of providing anchors without raising the temperature of the substrate. The anchors are shown here, and these are referred to as pins. And then the foils, or we refer to in the periodontal community as a barrier, the company refers them as a foil, and we'll describe why that is later, come in many different forms and shapes. Typically what's used is a 0.1 to a 0.3 millimeter diameter shape. And the idea is that we will use the anchor into the bone. We'll place the anchor into the bone, whether on the buccal or lingual surface. And instead of drilling the anchor through the foil or the barrier, we're actually going to weld the barrier on top of these anchors. So hence the name SonicWeld. The sonic pins come in different heights. They come in various different heights depending upon the density of the bone. They come in different widths. We usually only use 2 different widths, and we'll talk about that later. And the pins are contained into a clip magazine. This piece of plastic slides off the top, and the pins are contained in channels here, so they're easily accessible for the sonotrode, which is this device here. So the sonotrode has a sharp tip to it, and that will pick up the top of the pin. And this is what's going to deliver the energy to the pin to cause it to liquefy. This particular sonotrode has a light-emitting fiber optic cable right here and here. So in the recesses of the mouth, this will provide us with a little better visualization when we're placing the sonotrode. This sonotrode is attached to a small compact box. It's basically an ultrasonic generator, and that sits chair-side. So schematically, how these pins are placed is we use a small drill that is attached to an implant drill latch angle, and we create the hole, and then we pick up the pin with the sonotrode and introduce it into the hole, and then we apply the energy. And what happens is that the outside portion of this pin liquefies, and the inside portion remains stiff until we get to the end of the compression. So just a little bit of pressure is placed onto the pin. The outside portion of the polymer goes into the pores of the bone, providing an anchor, and the inside core is still rigid till the very end, and then it all liquefies again at a very minimal increase in temperature, only 4 to 5 degrees C, and the energy is then removed from the sonotrode, and this all takes place in about 2 to 4 seconds. And after the energy is removed, the entire pin hardens again, and the sonotrode is taken off. So this becomes an anchor, not so much a tack, but an anchor for the foil as outlined here, which will then get welded using the same sonotrodes to the top of this anchor or pin. As I mentioned, the foils come in a couple of different configurations. We use the term foil or membrane interchangeably, but they also make a mesh configuration. The company that has developed this material is KLS Martin, and they are really pioneers in this field, and their mainstay is actually in craniofacial fixation. So these meshes or plates are what is used many times to fix large bone segments, and do so with a bioresorbable or bioabsorbable material. The plates can also be used. We find little use for these in the oral alveolar regeneration field, and normally we are using the membranes, and using a box technique, which we'll discuss at the end, we use the meshes. We can also shape the foil or the barrier, and we do so with a water bath. Due to the unique composition of this 50-50 PDLA barrier, it has a very low, what is referred to as glass transition temperature. So that's just a fancy way of saying when does it become floppy and loose. And that's only a couple of degrees above body temperature, around 50 degrees C. So we can use a sterile water bath to help shape and form the foil or the barrier into three-dimensional shapes, which will become the shell or almost the cast that we want our bone to assume a shape. And we'll go over a technique that we've developed to show you how to do that a little bit later. All the components, the sonotrode and the tips, are in a surgical tray, making it easier to autoclave. Now, Gerhardt has come up with what I think is really a brilliant idea in what he refers to as the shell technique. As we all know, that one of the problems that we have in GBR is that if the barrier gets exposed, in other words, if you open up an incision line, the wound doesn't close the way we want it to, and the barrier is exposed, a lot of bad things happen. The barrier degrades prematurely, we can get secondary infection along the outside of the barrier, and the healing is very stormy. So what Gerhardt has done is to say, okay, what is the main function of our rigid barriers? And that is to provide space or provide a physical construct for the bone graft, usually a particulate bone graft. And why don't we use that barrier at that portion, usually a lateral wall, and then in the area where it's most likely to open, that is right over the top, let's use a collagen barrier. And I really like this idea of using two different materials in the two different places where we have two different needs for the material. Again, the rigid barrier to provide the lateral wall, and then the collagen barrier to provide some type of support, but also to be sort of a safety net in case the incision opens up. A simple but I think really brilliant idea that Gerhardt has brought to the table. This box technique, as is shown here, will use a mesh, a perforated mesh on the buccal or the lingual aspect, and then tent over the buccal and lingual constructs with a collagen barrier. So now we can readily augment on both the buccal, on the lingual, and depending upon the height of these meshes, we can also do some vertical augmentation using this technique. So where did this concept come from? Many times I joke with my patients when we're talking about implants, and my patients ask, well, what are they made of? Where did you get them from? And I usually say, well, we go down to Home Depot and we find what's on sale because that's usually what works the best. And with this technique, our joke is not far away from truth, because where this concept of using ultrasonic fixation actually came from woodworking. And so the picture of this tree here is to give us a sense of where the origin of this technique is arrived from. So where this technique came from was that initially there was a need to try to figure out how to put two pieces of wood together. And in the 1990s, there was research done on fusion of pieces of bone using ultrasonic energies. And here is a diagram describing how this was initially done. And you'll notice that the words are very similar that I used earlier, sonotrode. And what that is doing is delivering an ultrasonic energy to an amplifier, which is the tip of the sonotrode, and taking these polymer pins and driving it into the wood. And what this would do is that the polymer would then go through its glass transition phase and spread out into the porosities of the wood and then join the pieces of wood together. And what you would see is that you could join multiple pieces of wood together and they would almost be seamless. And this is used many times in furniture manufacturing today. So let's talk a bit about these biodegradable barriers and what we're looking for. First question we should ask is, why should we even use a bioresorbable barrier? Because we know that the EPTFE material has traditionally given us very, very good results, some of the best bone healing. But the problem that we would always have is that if the barrier opened up over the EPTFE material, our complication rate was very significant. So one of the reasons that we would want to use bioresorbable barriers is, number one, there's no retrieval. And the period of complications is shorter, and the incidence of complications is really similar to the inert barrier. And we are now finding out that our performance is actually similar. In other words, the performance of a bioresorbable barrier is very similar to that of EPTFE. So if the performance is similar and we have decreased chances for complications and we don't necessarily have to retrieve it, we really should be using bioabsorbable barriers, resulting in an ease of use. Well, I hate to bore you a little bit with some basic chemistry here, but I think it's important to understand because there's a lot of misunderstanding about all the different types of polymeric or bioabsorbable barriers. The group I want to talk about is the polyalpha hydroxy acids. So that's your PLA, PGA barriers. Many times the PLA, polylactic acid, and then the PGA, polygylactic acid, are combined together, and those are called copolymers. And a lot of the barriers, the GBR barriers that were on the market 10 to 15 years ago were actually copolymers. The crystalline polymers, as shown over here, have a repeatable structure, physical three-dimensional structure. But in between this three-dimensional structure or crystal, I'll call it crystallinity, you'll have an amorphous zone. An amorphous polymer has none of this repeatability. And this is important because it does affect the way that the barriers handle. Because an amorphous polymer is going to be softer, whereas a crystalline polymer is going to be more stiff and brittle. So if the manufacturer can tweak the combination of the crystalline component and the amorphous component, we can enhance the stiffness or, on the other hand, make the polymers softer. What KLS Martin has done has licensed a certain polymer, a Resomer, from Germany, and it has made a polymer that is completely amorphous. And this type of polymer is the one that works very well with the ultrasonic energies. The other ones do not. When these polymers break down, we sometimes experience a problem where we see a great loss of bone. And that is very much dependent upon the purity of the polymer and also what type of polymer is used. So not all polymers, when they break down, result in some low-grade, I don't want to use the word infection, but low-grade reactionary granulation tissue reaction to the degradation of the polymer. The polymers are broken down by hydrolysis, and what that means is that we have these long alpha chains that are normally stuck together with different forces, and then water molecules will get in between the chains and start to break them up. And that the hydrolysis process breaks the large chains into smaller chains and then allow the smaller chains to be enzymatically degraded by macrophages and multinucleated giant cells. The end result is that the products are degraded via the Krebs cycle. This degradation of the polyalpha hydroxy acids, that's PLA or PGA, sometimes results in a low-grade inflammatory response and an early decrease in oxygen tension related to this degradation. If there is a poor oxygen tension level, in other words, it's not very vascular, you will actually decrease the pH and cause a localized acidosis. And this results in some of the bone loss around some of the early pins and barriers that we saw 10 and 15 years ago. So the hydrolysis of the polymer is, again, very much dependent upon water molecules getting in between this carbon backbone of the polymer to initiate the degradation cycle. The factors that are involved in the rate of degradation and how the degradation, as I mentioned, is related to the inherent degradation rates of the polymer. It's also related to the molecular weight of the polymer and the crystallinity of the polymer. It's related to the surface area. A very large barrier or a very thick barrier or foil takes much longer to degrade than one that's very small. Some of the barriers or constructs have pores in them, and that will actually increase the degradation rate. So all these different parameters affect how long the barrier will stick around. Also, it depends upon whether or not the barrier is subcutaneous, that is, in a contained environment, or has been exposed to the oral environment. We would tend to think that a barrier that's exposed to the oral environment would degrade at a faster rate than one that's subcutaneous, and the opposite is actually true. For the SonicWeld material, we are looking at this polymer right here, the poly-DL lactide, and typically its degradation rate is around 12 to 16 months. And that is what we also see clinically. Now, the manufacturer will say that it degrades 6 to 8 months, but that's really not what we're seeing clinically. It still is a little bit around when we re-enter at 8 months, and we do have radiographic evidence that it's there in the more apical portions a little bit longer. I see this as an advantage instead of a disadvantage because it provides a little bit more stability for the graft later on. So when we are comparing EPTFE to a polymer barrier, we know that EPTF alone results in really the best healing, and there's a plethora of literature to support that. But grafts are necessary to provide that space for an EPTFE barrier. Bioresorbables must contain the shape long enough for regeneration to occur. So a very soft barrier, polymeric barrier, is nice for handling and is nice for the soft tissue, but it may collapse too early. And we see this obviously with our collagen barriers, where if we don't provide a construct, in other words, a graft material that degrades slowly, we get a very marked decrease in the volume of our graft material. So the bioresorbables must be stiff enough to maintain their shape if no graft is used. But if you increase the stiffness and decrease the adaptability, this impairs the soft tissue coverage. So I include this slide here to reinforce that from a bioengineering standpoint, it's really a balance that the manufacturers are trying to achieve. Well, let's talk about the basics of this technique. The basics of the technique are that we're going to create a space for our graft material. And the way we're going to do that is to provide anchor pins somewhere, either on the buccal aspect or sometimes on the lingual aspect, and we'll talk about how to arrange that later. And we're going to use our foil, and we're going to weld the foil to the top of the anchors. If we're using the shell technique as described by Dr. Eaglehout, we will take the top of this and use the collagen barrier of your choice over the top of that, and then the flap closes up on that. We will show cases of vertical augmentation where we don't use the collagen barrier and we actually take this shell and go all the way across in a dome shaped from the buccal to the lingual aspect. So I'd like to show you some videos of the pins being drilled into the bone, and this comes from one of the offshoots of the wood welding company that licenses this product. And one of these companies is involved in spinal reconstruction, and this is a video from this company, and their company is called SonicWeld, but it's actually an in vivo inserted into live bovine vertebrae. And I think it dramatically shows you how the melting, quote-unquote, process occurs. So this is a 3.5 millimeter pin that's going to be drilled into a 3 millimeter hole. So here's the pin driven in, and what we're going to do is we're going to look at this in slow motion, but this gives you a sense about how fast this goes. So what you'll notice is that the top of the pin, this middle core portion, is clear, and that's the area that is still solid. And it's the outside portion that melts, so to speak, into the pores of the bone. And then the energy then will subsequently cause the inner portion of the core to melt or go into its glass transition. And the energy is then removed, and then it solidifies. And this all happens within about 2 to 3 seconds. The next video that I would like to show you is really a demo video of how I use this material on a day-to-day basis. And what I have here, let's see if I can pull up this. There we go. What we have here is just a block of wood. And that block of wood, we are going to simulate a a defect, and I'm taking a titanium mesh, and this is a flexible titanium mesh, and I'm bending it into the proper shape that I want. Then we take the foil and place it on top of the mesh and put it into the water bath. Now, the mesh is not going to go into the surgery site. The mesh is actually a frame to give my plastic the right shape. So we put it in the water bath. The foil becomes very flaccid, so to speak. Then we slowly lift up the frame out of the water bath, and it assumes the shape that we want. We then drill usually 2 holes is the technique that I use, and minimizes time in the mouth and decreases the cost. We're then going to use the magazine or the cartridge that has the pins, and we're going to take the sonotrode that has a sharp little point in the middle, push down, pick up one of the pins, pull it out of the magazine. There we go. And this is a very short pin. This is only a 3 millimeter pin. And we place the pin into the hole and then apply the energy, and you'll see it melt very quickly. We let go of the energy. I rotate back and forth and release. This is placing the distal pin. So we have both pins placed, and we take our pre-shaped foil, which we shaped out of the mouth, and then we weld it. So this ultrasonic welder, you just apply the energy on the end, and it welds the foil to the anchors. And this in cross-section gives you a sense about how we've been able to adapt this very, very quickly into the shape that I want my alveolar bone to become. So that's the basic technique. And let's talk about some of the histological evidence. Gerhard, Dr. Egelhout, is doing work in Germany, and he is doing core biopsies of lateral and vertical augmentations using both autogenous bone and bone constructs made with bioos. And these are some Van Giesen stains showing that we get live vital bone at 6 months. And we'll show you a toluene blue staining here. And this is bioos at 6 months combined with autogenous bone. And this is autogenous bone alone. And as you can see, we've got new bone growing here with osteocytes stained intensely blue here, showing the new bone growing on the old scaffold of the old bone. Looking at what happens with these plastics that are sort of being driven into the bone, we want to ask the question, is this doing any damage to the bone? And studies have taken a look at that, and we're going to review some of the histology in this slide here. So the area where the pin is in this area right here, and at a few months you can see new bone formation, which is outlined with this darker blue with the letter N, osteocytes viable, and a higher powered magnification. Here's a nice fat osteocyte, being very, very happy in a short distance away from where the polymer moved into the native bone. The arrows are really just a histological artifact of separation during the processing. Well, let's talk about some clinical cases, and again, we all have a tremendous debt to Gerhard for coming up with this really great idea of the shell technique. And where the shell technique is used is mainly for lateral augmentation. So I'd like to discuss this first patient who presented with a need for both a sinus lift and a lateral augmentation. And this occurs, I think, very frequently where a patient may lose a second premolar or first molar. And we sometimes get over-fixated on the vertical augmentation, but we forget that many times these patients need lateral augmentation, especially if they have a wide smile line. So what we're going to be doing is a sinus lift and a lateral augmentation. And this is how the Panorex presents. And we are going to be augmenting the sinus here, but we're also going to be doing some lateral augmentation in the premolar area. And we're going to show you a video of that. And we'll start it right now. And we're using the ultrasonic approach to, the piezoelectric approach to getting the window. And this is the Mectron piezosurgery device. And we will be using a back action insert to thin the bone out and define our margins, and then we will come in with a flat-sided diamond to smooth the edges of the osteotomy before we do our elevation. We do use quite a bit at a low energy amplitude, the inserts, which provide a nice irrigation and also at the same time provide for easy access. And you can see we have it perforated that we know of. As the patient is breathing, you can see the membrane move up and down. So here's the first pin that's been placed. So I place one in the mesial, I place one in the distal, and sometimes I'll place two in the mesial to give almost a tripod effect. Here's the sonotrode with the pin in place. We apply the energy that goes into the porous bone. The energy is released. We twist the tip and it releases. A little bit closer magnification view and the distal site. Apply the energy, goes right into place. The head mushrooms out. Take off the energy, rotate the tip, and come on off. So now I'm sort of have identified the position of the anchors, and what I'll do is shape the barrier, take measurements, and we're going to anchor it with those two. Some clinicians will use 3, 4, sometimes 6 different anchors. I think that if your foil is shaped the right way, you only need 2, and that also, again, keeps the cost of the procedure down. So as you can see, I am anchoring the foil to the, I'll call them the tacks, and they are essentially being welded, and it really takes only minutes to do that. The sonotrode can also be used to bend intraorally the barrier or the foil, or to get rid of sharp edges by applying this ultrasonic energy to induce some rounding of the barrier. I prefer to do almost all of my shaping outside of the mouth and very quickly deliver the barrier to the mouth and tack it into place. So here is the barrier that's been packed with bone. We use PRP with Mineros. The PRP is used really to give some stability for the graft. We really don't know how much it enhances the biologics of it, but I do like what it does for the stability of the graft, and we do know that it accelerates the soft tissue healing. And you can see in this last view that the collagen barrier has been adapted over the entire construct. And we'll go back to the slide sequence. So here we are showing you why we needed to do the augmentation, and that is from our CBCT simulation. We see that if we place the implants where we want them to be prosthetically, they would perforate the bone, so we needed lateral augmentation in that area. So here's the simulation of the pre-treatment, showing that if I place the implants, they perforate into the sinus and need some lateral augmentation. The closure is, I think, very straightforward. We use a mattress suture to take up the tension in the flap, and this is usually done with CV5 gore or CV7 gore. And then 6.0 or 7.0 Proline is used to close the incision in a passive manner. This is our healing at 1 week, and we feel good because it looks like we've got some good primary closure. And this is our healing at 6 months. And I want to draw your attention to a couple of things which I think are unique that we are seeing. First of all, we can see from the cone beam CT that we have this nice callus of bone out here. And that is great because this is where we wanted our bone. But I draw your attention to this line that you see right here. Now the barriers don't show up on cone beam CT. They're radiolucent. So what is this line that we see sometimes with these barriers? And what we're seeing is that there seems to be an increased deposition of mineralized tissue on the outside portion, depending on your perspective, or on the inside portion of these barriers. I think this is a significant finding because this is showing that bone deposition is occurring in the area immediately adjacent to these foils. So concerns about the degradation of the polymer causing a localized acidosis and decreasing bone deposition, we seem to have radiographic evidence that just the opposite tends to occur. So we then come back and do our simulation with a surgical guide, as you can see in this view right here. Here is that bone deposition on the outside of the barrier. The tubes in my guide say that if I place my implant right here, we've got good volume of bone and hopefully a nice successful result. Here is our reentry, and again this is at 6 months, and you can see the remnants of the collagen barrier. There we go. Collagen barrier right over this area here, and a nice dense bone fill allowing me to place my implants so that they prosthetically are where they should be. Pre-treatment on the left, post-treatment on the right, showing the degree of lateral augmentation. 2 months after implant placement, the soft tissue healing looks good. And these are obviously cover screws, and we're gradually expanding the soft tissue so that we have a nice emergence profile in our tissue. And at 4 months, referred back to the restorative dentist, who in this case is a magnificent, talented technician, restorative dentist. And his name is Dr. Denny Byrne here in Baltimore, and some of these cases that you'll see have been restored by him. Just beautiful, beautiful restorative work done by Denny on this case. But I think we ended up with a nice result because we were able to actually bulk out the smile corridor in this area here and provide this patient with an aesthetically pleasing contour in this area because we augmented both in a vertical direction and in a horizontal direction. And I don't think we could have done that with many other procedures on the market right now, with the exception of a block graft. And that's where I think the SonicWeld really fits in well, because in my practice, we no longer use block grafts because we can achieve almost a very similar result with this technique. I'd like to show you another case of a lateral augmentation, and this patient suffered from excessive decay secondary to the medications that she was on. She has a very dry mouth, xerostomia, and needs a lateral augmentation of the mandible. Now, we're not trying to go for a tremendous amount of augmentation in this situation, really just about 5 millimeters of lateral augmentation and about 7 millimeters of vertical, but we have vertical on the lingual aspect of the implant. So it's not a true total vertical augmentation. It's more of bulking out the corners. But I'm showing you this video to give you a sense, high-powered magnification, which we shoot under a microscope, to show you what these pin placement looks like in the mouth and how easily these are done. A basic technique is to be very deliberate. Crustal incisions, we try to go through the thickest portion of the keratinized tissue. This enhances our post closure, so to speak, so that we can use a mattress underneath the KG and then use a separate suture to close over top. I'm going to show you a technique that we use routinely as far as splitting the flap, and we like to start our splits from a vertical. Obviously, we have to plan the vertical carefully, and if you look under a scope, many times you can go in between blood vessels and get almost a bloodless vertical. So we'll then reflect the flap just to about 1 millimeter below the mucogingival junction, and then we will come back to that vertical incision, as you can see here, and do our split thickness dissection from the anterior or from the vertical. This is a much easier and safer way of doing split thickness dissections. It dramatically decreases your chances of perforation, but allows you a significant amount of flap mobility. So again, coming from your vertical and splitting, starting on that plane, rather than coming from an apical to a coronal to an apical direction. So we are then coming back and getting a little bit more release by splitting the periosteum. And my test about whether or not I have enough vertical mobility in the flap is to see if I can pull the flap with minimal tension to the occlusal surface of the tooth. The burr hole has been placed. We apply the energy, stop the energy, rotate the sonotrode, and lift it up. It's as simple as that. And we're now in the posterior part. Apply the energy. You can see the light go on. It mushrooms, the head mushrooms, rotate, and come on out. So again, this is different than tacks that we've used in the past where we're going through the barrier. We're going to weld the barrier to the top of the tack. We do our decortication, and this is a barrier that has been bent in the mouth, and outside the mouth. And if we could go back to the slides, what we're going to see is that I wanted just to maintain a portion of the curve. So I am not going to be using a complete dome shaped here. What I wanted to do is I wanted to get this portion of the curve. So I dip it in the water bath on just one side, and that will curve it. And then I'll make the cut so I have the open portion, which will be covered by the collagen barrier, but I still have a little bit of a curve to it so I don't have a sharp edge. So there's our curve right here, and that came from this portion here. So the cut went right across here, and this is what I have left. We then tack it in the mouth, and unfortunately these don't photograph very well because they're translucent, but this is the edge of the barrier as outlined with these black arrows. So here's the curved portion of the barrier. The barrier is now forming the buccal wall, and then we pack in the bone on top and then put a collagen barrier on top of that. I don't think it really matters what collagen barrier is used. It's really what you're most comfortable with, but something that has a little bit of rigidity to it. So here's a post-op CT showing the lateral augmentation achieving what we wanted to get. Let's go over another case, and this is a patient presenting with a lot of periodontal disease and again needed lateral augmentation and a sinus lift procedure. This again is the shell technique, and there's our pre-treatment. And if we do our simulation, we can see that because of the buccal undercuts, if we place the implant in the prosthetically ideal positions, we're going to perforate and just not have enough anchorage for this, these implants. So we will make the incision, go to the water bath, bend the barrier in a curved fashion, place our tacks, as you can see right here. Tacks are placed, the barrier is then welded to the tacks, then bone is packed into the space, and then a collagen barrier goes over that. So here we are 6 months later, and you can see that we were able to get the sinus lift. And if you look real closely, there's a little bit of a pilot error here. I did not go anterior enough with the packing of my bone. I think this has nothing to do with the technique, but is more of sloppiness on my part. But what we were able to do is get a good lateral augmentation in this area here, which relates to this implant in the first premolar position. So here is the healing at 6 months, and you can see the lateral augmentation. If you look real closely, you can see this frosty material right here. This is the remnants of the bone, but I'm showing you this to emphasize that there is not a negative degradation to this polymer that I have seen. You can see a callus of bone developing right over here, and this happens to be right in the area where the collagen barrier was. And from an occlusal view, you can see the width that we were able to achieve and be able to get our implants in an aesthetically, in a position that will be aesthetically favorable. Here is our healing at 2 months with our gingival formers. And again, Dr. Denny Bird did a beautiful job of restoring this case with 3 separate implants, 3 crowns on 3 separate implants. The last case that I'd like to show you as far as the shell technique is this mandibular posterior lateral augmentation. And the patient needed lateral augmentation for the best prosthetic alignment. The restorative dentist took care of the supererupted tooth on the upper here to give us an occlusal plane that we can deal with. And here is the pre-treatment view. And this is the view of the split thickness dissection. So if you look very closely, you can see here is the periosteum here. We will then, after we do the split thickness dissection, release this periosteum. We'll just elevate it out of the way. And if I can, I will take this periosteal layer and place it over the most apical portion of the barrier in the tax. Pre-treatment, we see that this is a very narrow ridge between 1 and 2 millimeters. And we place our tacks. In this situation, I placed 2 tacks here and 1 tack posteriorly. And the reason I felt to do it this way is because this would give me a better chance of managing the 2 different planes that I have. Well, what do I mean by 2 different planes? Well, the buccal aspect of the bone in the second premolar position is the plane is sort of vertical, but as you go posterior, it starts to cant. And it's a little bit difficult with just 2 pins to anchor down the barrier when the pins are in 2 different planes. So when we have the pins in 2 different planes, fore and aft, we need to use 3 pins to sort of give it a tripod effect. So here's the barrier in place, and you'll notice that the barrier that I'm using here is one that has perforations in it. And we're tending to use these a little bit more in areas where I think that the tissue is a little bit on the thin side. In other words, if the patient has a mucosal type that is very thin, I want to err on a barrier that, if it does perforate, will degrade a little bit faster. So this is another type of foil that has the perforations in it. Our bone healing seems to be the same, whether it's a solid foil or one that's perforated. We pack the area with bone, expanding it out a little bit, and then place a collagen barrier, and this is cytoplast, over the edges of the foil. Here's our closure using a similar technique as described before, and that is one horizontal mattress taking the tension of the flap, and this is either 6.0 or 7.0 Prolene to gently adapt the wound margins. At 6 months, we can go from that situation to this situation where we've been able to go to about a 6.5 millimeter ridge that will really provide me with a good stability and good bone width for placement of either a 3.5 or a 4 millimeter diameter implant. Here we are using the deplaque method of using surgical guides. These are radio dense guide tubes which provide us a nice idea of where the implants should be placed. And then the metal inserts will go on top of that. The reason I like these ceramic guides is that they provide an image that is relatively free of any scatter. If you use the metal tubes, you get a lot of scatter from these when you're doing your cone beam CTs. If you're using this straight barium sulfate impregnated acrylic, sometimes we don't get the definition that we want to see. So this is a real nice system that we like using a lot. Here are the implants placed, nice dense bone, and then healing at 4 months, ready to be have the tissue expanded with temporary abutments and ready to restore. Another good friend of mine, Dr. Fred By in Hagerstown, Maryland, has actually done a tremendous amount of clinical cases with SonicWeld and has just an amazing library of cases. And I wanted to share this one with you. Fred is also just a tremendous periodontist along with his wife, Rebecca. They do just a great job of providing wonderful augmentation services for their patient. So Fred had this case where the immediate removal of a hopeless central incisor. He's augmenting, as you can see, is required through his Simplant simulation that he really needs to have a good 4 or 5 millimeters of labial plate augmented. And if you look closely, you can see the outline of the barrier right here. And he's got 2 tacks here, 2 tacks here, packed in with a allograft with PRP, and then the barrier is draped over and primary closure is achieved, and he can go very easily from situations such as this where he has this concavity pre-treatment and then he has this extra bulk of bone post-treatment using SonicWeld, and Fred is just a wizard at this technique. So here we are at re-entry of Fred's case. These are BioHorizon laser lock implants, and you can see the thickness of the bone that Fred was able to provide his patient, allowing him really a nice surgical result and straightforward placement of these implants that really couldn't be achieved very readily with any other technique other than a block technique. But of course, we don't have the morbidity associated with it. Well, what about vertical augmentation? We know that lateral augmentation is quite common and can be achieved with quite a few different techniques. And I think we've shown you that in significant lateral augmentation necessities that the SonicWeld procedure works very well. But where the rubber meets the road, so to speak, is in vertical augmentation. This has always been our clinical challenge to do this. In the past, we've resulted to blocks or DO, distraction, osteogenesis, and those have not been very straightforward procedures for the patient because of the comorbidities associated with either harvesting or with the transport of the bone segments. I think that the SonicWeld procedure really provides us with a very nice alternative to those procedures when we have a vertical augmentation need. So let's take a look at a couple of cases. This case is, I think, unique in that the patient was quite young, presents with aggressive early onset periodontal disease, a lot of alveolar bone loss. A full rehabilitation is required, but the complicating factor that we had is that he had chronic sinus disease, and we could not pre-treatment clear up the inflammation in his maxillary sinuses. So we could not go to the maxillary sinus to get some vertical augmentation for our implants. And this created quite a dilemma. So this is the way that the patient presents. Again, only 34 years old, tremendous destruction of the alveolus. And how do we approach this? So here is the patient from the left-hand side. I'm going to be showing you a lot of cone beam images on this particular case because this was one that was really pushing the envelope. As you can see, there's an 8 millimeter implant simulated here. We may have only 4 millimeters. one aspect, 5 millimeters vertical height in the premolar area, nothing posterior, and very little in the anterior. So how are we going to provide a fixed rehabilitation to this patient? And I think we were able to achieve that using this frame technique, which I described earlier in the technique video, and we'll show you a couple of cases using it right now. So on this side, on the left side, first thing we do is debride the defect. We place our apical anchors, as you can see right here. We then adapt the wire frame, and again, this is adapted intraorally. So this is not part of the bone augmentation environment whatsoever. It's really there as a frame. Think about if you were pouring a concrete sidewalk, you would make a left and the right side to it with wood. Well, we're doing something very similar here. We're creating a cast or a frame, and we can either do this intraorally or we can do it on a stereolithic model to get an idea of how we want this shape to be. My idea here is to minimize the amount of time that we're in the mouth with the barrier. Go in, tack it, pack it, get out. That is my mantra. The shorter period of time that the patient has this wound open, the better the healing we're going to get. So we adapt the frame in the mouth to what I think should be the ideal shape. We take the frame out of the mouth, rinse it, and then put the foil on top of the frame, and then together with a hemostat or curved needle holders, dip it into the hot water bath. The plastic becomes flaccid. It then drapes over the drapes over the metal frame. You slowly raise the metal frame out of the water bath, and then it has achieved its shape that you want. Remove the wire frame and then tack that the foil that has been curved into the dome shape that you want using your tacks, either 2 tacks or 4 tacks, whatever you feel is required to necessitate stability. So this is at 5 months on that left-hand side, and you can get a sense of the vertical augmentation that we've been able to achieve. We've almost tripled the amount of space here. This is a 10 millimeter implant, so we have about 15 millimeters of length here. We ended up using 13 millimeter implants in this area, where before we had barely enough bone. Going to the other side, we're going to show you the last video and showing you the technique that we use. We have a very similar need, and that is we can't go to the sinuses, and we have to really augment in the premolar and the canine area. So if we could show the last video here. There we go. So here we are perforating after debridement has taken place. The size of the holes and the number of the holes, I think, is a little bit empirical, based that upon the density of the bone. Here's the wire frame that I've adapted, and these are reusable. Again, KLS Martin will supply these. And I'm adapting it in the mouth, getting a sense of what should be the shelf, the prosthetic shelf, so to speak. Here we are holding the two together, the wire frame and the foil, and we're going to go to the water bath, and you can see that the foil adapts, and then we have the foil in place. It's sort of hard to see again because it's translucent, and we've placed the tack in the anterior. Place the tack in the posterior. And these sonotrodes come with different angles. So earlier we were showing a straight sonotrode, and this one is angled. And here we are tacking the barrier or the foil in place. And then we lift up the one edge of the barrier and pack the bone in. And that's why I like to use just 2 if I can, to keep the cost down again and to also allow easy placement of the bone underneath the barrier. Okay, if we can go back to the slides. Great. So here we are on that right side, and this is at 5 months, and we do a preliminary assessment, and it looks like we were able to get our vertical height that we wanted to, maybe a little bit less than what we had on the other side. And now we're going to try to remember where we are as far as prosthetically driving this case. So this is going to be hopefully a hybrid bridge. And so what we want to do is be very cognizant of our prosthetic spacing that we need. So we take his denture, duplicate it. So this is his transitional denture that he's been wearing. We duplicate it in Ivoclar's barium sulfate resin. And then I place where I would like the access holes to go if I was using or creating a fixed detachable type of case. So we were looking at the premolars in the canine areas, and using this translucent barium sulfate impregnated acrylic, we can really get a nice sense from a three-dimensional perspective of whether or not we have enough vertical height for all my prosthetic components. So this is the inside of the denture. This is a mucosal aspect here. And what we want to evaluate is that from the level of the mucosa to the top of the denture tooth, or whatever our prosthetic material is going to be, do I have enough vertical space? Because this is a very common error that we make in implant dentistry, and that is not to provide enough physical space for all the prosthetic components that we need. So we take that denture, put a little bit of denture adhesive on it, lock it in with a check bite, and then rescan the patient. So here we are with the barium sulfate impregnated duplicate denture. Channel guides have been placed, and I'm simulating where the implant is. So this is in the number 12 position. If I want this ideally, I'm a little bit shy here, so I'll either move this off to the left a little bit or towards the palate, or I will augment a little bit more at the time of implant placement. So this is the technique that we use, and then we will come back later and put in a metal guide to guide the pilot drill, and that slips right into these holes that we have drilled. Looking at the right side, we've got the adequate amount of vertical distance between the top of the platform and where the prosthetic table is going to be in this first premolar area. And again, this is a 13 millimeter implant that has been simulated. A little bit further forward, we have plenty of room for what we need. So if we compare where we came from on the left-hand side to the right-hand side, we've gotten a dramatic vertical augmentation and also of width that changes the prognosis of this case dramatically. So here are the metal inserts that are placed in, which we've done minor tweaking as far as the positioning of the tubes, a little bit more to the palate on that one that you saw. And what we will do is then we will take 2 screws and then screw this into the palate. So this is almost like a poor man's guided surgery, and then these metal tubes will provide guidance for the pilot drills that we'll be using. So here we are at re-entry, and this is 8 months later, and you can get a nice appreciation of the thickness of the bone. So these are 3.5 millimeter implants in the anterior, a 4.3 in the posterior, but a plenty of width of bone. We really could have used almost any width up to a 5 if we wanted to, and our vertical height was 13 millimeters on all implants. So we'll let him heal and get into the restorative dentist, and he'll be off to get restored, I think, with almost any type of prosthesis that the prosthodontist wants, because we've got 6 implants, great length, and they are in the right location. A more challenging case is vertical augmentation in the posterior next to a tooth. This is something that you really can't do, I think, with any type of other augmentation. So this is why I've included this for you. This patient had number 31 extracted due to root resorption. The patient wanted an implant. I said we rarely replace teeth in this position, but the patient developed some TMJ issues and begged me to place this implant. We shared with her the difficulty in getting vertical augmentation in this area. And one of the reasons that we needed vertical augmentation in this area is that from the CT scans, you can see that this is an 8mm implant that's simulated. I'm out of the bone, and I've got the nerve sitting right there. So my native bone is really only about 6mm. If I want to do a minimum 8mm implant, I have to get some kind of vertical augmentation going on here. And again, the reason that I have included this in this discussion is that I think the SonicWeld procedure by KLMS Martin is really the only one that's going to achieve this. So here is our pretreatment view, very little attached tissue. Since the bone was quite dense or cortical, we use a larger perforation scheme. The two pins are tacked right here. And the difficulty that we're sort of managing is how close do we come to the back end of tooth number 30 with our barrier. We don't want to come too close so that we get primary closure, but on the other hand, we have to get close enough to provide a sufficient amount of bone. We use the same technique that I've been referring to, which we call this frame technique. So I adapt the frame in the mouth, then I take that frame combined with the polymer barrier, put them together, dip them in the hot water bath, slowly raise them, and then the polymer barrier assumes the shape of the wire frame. And so you get a nice sense of it right here. So here's the curved barrier on top of the bone, tacked once in the front on the buccal and once in the back on the buccal. It's very, very difficult to tack this far posterior on the lingual aspect. So again, this is why we like to use this particular pre-bending technique. So post-treatment, what we are able to achieve is a vertical height of 12mm in total, and you saw that we were starting with around 6 to 7, so the amount of new bone is from here to here, and this is quite challenging to accomplish in this environment that far back and with this thin characterized tissue. So here's the implant placement, and this is 1 year later on the BioHorizons laser lock implant, and this is actually a 10.5mm implant. So the last case that I'd like to share with you is again a very challenging case, and the purpose of my sharing this with you is to give you a sense of what this technique can accomplish. A 72-year-old female presented, and what had happened is that the prior periodontist had done a very good job trying to do a sinus lift, but unfortunately there were many complications and the patient developed a sinusitis, and the majority of the graft was actually lost. In the process of the loss of the graft, you can see the significant vertical loss, and this is almost 8mm in vertical height of loss of the alveolar bone. So if we think about treatment planning in this case, do we come back and do another sinus lift? And the answer is, well, even if we could get to make the sinus lift work, we would end up with a crown to root ratio with numbers that I think I would need a calculator to actually figure out. So the key to this case is not to think about augmenting in this direction. The key to this case is to augment in this direction. Both are vertical augmentations, but one is going in an occlusal direction as opposed to an apical direction. But this is a challenge. So here we are with the simulation. You can see that there's a minimal amount of bone left on the alveolus. This is the sinus, which is not a very happy sinus. You can see that there is some type of mucosal thickening here. So what we want to do is just stay out of the sinus completely. When we simulate with 10 millimeter implants, these are 3.5 by 10s and this is a 4.3 by 10, we can see that if we want to get anywhere close to the occlusal plane, and we're 3 millimeters below the occlusal adjacent crown height here, CEJ height, we have no bone to anchor these implants at all. So we need to challenge ourselves and see what we can get. When we open up the case, we can get a sense of the amount of vertical destruction. This is a spontaneous perforation into the sinus because of the lack of healing here. So this is actually the floor of the sinus right here. So we use the same frame technique, place our tack in the front and then another tack posteriorly. You can see that the curvature is a little bit more multi-dimensional. We want not only a curve in a coronal direction, but we have to come in and adapt to the palatal aspect here and adapt to the palatal aspect here. Because this amount of augmentation is so wide from a mesial to distal direction, we are actually engaging some of the curvature of the posterior palate and the anterior palate. So here again, same technique where we take the foil and let's see if we can grab this. There you go. Take the foil, place it right next to the bent frame, dip both of them in the water bath, slowly raise the frame and foil together, and then the foil, as it cools, adapts to the shape of the frame. We then come in and I do my tack here, and there's a posterior tack way back here, and this is not fixated on the inside surface because what we do is, so I apologize, here's the tack in the front here, the tack in the back. So what we do is we actually lift the palatal aspect of this, rotate it up, pack the bone in, and then just rotate it back down. So you can see the amount of vertical height that we're trying to achieve right here. And in this situation, even though this was dome-shaped, we don't necessarily need to have a collagen barrier. The mucosa was very, very thin from the prior surgeries. So anticipating that if the wound opened up, I would then be on a collagen barrier instead of on the outside of the foil. I wanted to use that. So I don't always place a collagen barrier over the curved aspect of a vertical augmentation. It is very much dependent upon the shape and the health of the mucosa pre-treatment. Here we are at 1 week healing. You can see the horizontal matrices. There's actually two placed here. One here, one a little bit more posteriorly, and this is our 6-0 proline, but we are lucky enough to get primary closure here. And this is the healing at 3 months. So our initial incision line is actually right here. And the good thing is that we have maintained primary closure over our construct, and we're probably going to end up with a very nice bone fill. I'll show you an early cone beam CT of this. But immediately your mind should go to, this is a mucogingival difficulty, and there's no question about that. So when we go to place the implants, whether we place it in a 1-stage or 2-stage approach, there's going to have to be some sliding palatal flaps to get an adequate zone of attached tissue on the outside portion of the implants, that is to the buccal aspect. That is a downside of this technique, and that is that any time that you're trying to achieve primary coverage over a bone graft, you many times end up shifting the mucogingival junction towards the palatal or towards the lingual, and that has to be compensated for in your final mucogingival surgery when the implants are placed. So let's take a look at what the cone beam CTs are showing us. And what we can see at 4 months, we are getting a vertical augmentation in the area of 10 to 12 millimeters. You can see some of this condensing radio opacity that occurs next to the edge of the barriers. This is the old floor of the sinus, so we were able to get this amount of height. We've simulated the implant placement, and it looks like we're going to have enough vertical height for 4 implants. And this is a ghost image using the cone beam CT showing that we're getting good buccal contours also. I will let this case go out a minimum of 8 months before we come back and do our simulations again with a surgical guide and begin to place the implants. As I mentioned earlier, we can do these foil and frame constructs off of either what we are presented with in the mouth, but if we want to even decrease the time that we're doing that and pre-bend these foils or pre-shape these foils, we can do so based upon a stereolithic model. And here's a case that Fred Bai, as I mentioned earlier, who has tremendous experience in this, is getting an idea of how to bend the three-dimensional titanium mesh so that he has a better idea of where his foil is going to be adapted around the teeth. So in summary, I'd like to talk about the advantages and the disadvantages of this technique. The advantages are that I think this is a very good alternative to blocks. Some people have suggested that this may be a great way to provide containment for the recombinant BMP2 sponge. Right now, one of the problems that we have with that vehicle is that we can get some compression of the sponge, and if you over-compress the sponge, that increases the local concentration of the BMP, and you can get some untoward effects of that. So many times our BMP2 is hydrated or combined with different forms of block carriers or particulate carriers, and the problem with that is that it alters the concentration that sort of has a sweet spot. If we use the SonicWeld, this may provide enough physical support to put the sponge in a passive manner and get the right concentration in the recombinant BMP sponge. So that is one of the things that we are looking for into the future. After a learning curve, I think this is actually a very easy and fast method to provide space for graft material. If you use the frame technique that we described, you can actually get in and out of these surgeries faster than any other technique because you've done the work outside the mouth pre-treatment if you're doing it off a stereolithic model, or you have done it outside the mouth right after you've laid the flap. This helps to keep the foil or the barrier free from contamination. You minimize that, and also allows the surgery to go much more quickly. It's bioresorbable, no need for a second surgery, and this is where I think this material has a distinct advantage over EPTFE. Even though EPTFE gives us histologically some of our best results, management of the material can be a problem. The cost is comparable to titanium reinforced gore. These dollar amounts may not be perfectly accurate based upon inflationary concerns and also where you purchase the material. But the bottom line figure is that a foil and 2 pins is around $300. And that is very similar to what you get with a titanium reinforced gore. That also includes the cost of a low-cost collagen barrier. So if we're looking at this from a healthcare perspective, an economic perspective, this is not very costly when you use this technique. Not as least expensive as a block can be, but again, there is no morbidity, enhanced morbidity associated with this. What are some of the disadvantages? Well, it's a lot less costly barriers are available. Obviously, the collagen barriers are the most dominant barrier on the GBR market, but the problem with collagen barriers is that they are fantastic for smaller lateral defects. You need to have a substantial amount of graft material to hold them in place, and you get some slumping with that. So this technique I would not use for a moderate lateral defect. I think that's overkill. For a sizable lateral defect and for vertical augmentation, I think that's the sweet spot for SonicWeld. The reason for complications with GBR are common to all barriers. It's not really so much related to the barrier material, it's what you do with the flap. And I think this is where Dr. Eaglehout's brilliance really comes in, and that is the recognition that if the flap opens over your incision line, put a collagen barrier there, but yet still get the advantage of the lateral reinforcement from the SonicWeld. Just a great idea. There's an initial investment. The SonicWeld and its componentry is anywhere between $4,000 to $5,000. That number may vary depending upon the locale. So there's an initial investment that's there that has to be included in the analysis of the economics of this. There's lack of evidence-based data. Like any new technique that comes onto the market, we want to adhere to evidence-based practice as much as we can, but we have to also acknowledge that we don't have a lot of evidence-based data, case-controlled or randomized controlled study data available. Out of Germany, we are getting more and more histologic data of core samples that have demonstrated that the stuff that you get is bone and is, in our hands, showing that the bone level is maintained very well. This lack of human and animal histology, I think, will change over time as the research expands into this field. Documentation of the resorption kinetics is always a slam on any bioresorbable. We don't know how it resorbs in the human model. There's great animal histology, but the human model can be very different and site-specific, so we need to get more documentation of that. I'd like to thank you very much for taking time to spend with me on this Dental XP webinar. It's been a great pleasure to be able to present to you this idea and this concept for a course that is going to be given in later in November at the University of Maryland. We can give you some hands-on ideas about how to use this material. And if you have any questions, you can contact me at info@periopros.net, and feel free to give me a call at any time and be glad to answer any questions that you have. Thank you very much and have a great day.